Our next topic on differently abled children or children with special healthcare needs is cerebral palsy. It is a group of non-progressive disorders resulting from malformation of motor centers and the pathways of brain. As from the definition itself, it is a non-progressive disorder. It won't progress. The malformation which is there, that won't progress further. And it is due to the motor centers. So there is malformation in the motor centers of the brain. And this lead to, either it can lead to paralysis or weakness of muscles, or it can be incoordination or lack of coordinations of muscles. And this condition can either develop perinatally or prenatally or immediately after birth, that is within the first 5 years, or just before the 5 years where the CNS have reached the maturity. So if anything happens during the developing brain, it can affect or it can lead to cerebral palsy. So it can be either prenatally or at birth or within 5 years after birth. So anything or any damages that cause to the developing brain can lead to this condition. So there are different types of it. That is, depending upon the neuromuscular or which are areas are involved. That is the most common one is a spastic type. Then comes the athetotic or dyskinetic type, or otherwise called as chorioathetotic type. Then we have ataxic type of cerebral palsy. Then there is rigidity. And finally, it can be mixed or combination of above. That is spastic and athetotics combined, or spastic and ataxic combined, or spastic and atastic and rigidity combined. So a mixed type also can be possible. And next is according to the area involved, whether it can be hemiplegia, that is one part of the body will be involved. It can be either the right side or it can be on the left side. That is called as hemiplegia. Half of the body is involved. Paraplegia, that means either your lower limbs or the upper limbs is involved. That is paraplegia. Then we have quadriplegia, that is all the 4 limbs are involved. Then it is called as quadriplegia. And monoplegia, if only one part of the body or one limb is involved. Either it can be the right upper limb, or it can be the left upper limb, or it can be right lower limb, or it can be the left lower limb. Or if any type of one extremities is involved, it is called as monoplegia. If 4 extremities are involved, it is called as quadriplegia. And if the half of the body is involved, either the lower limb or the upper limb is involved, it is paraplegia. And hemiplegia, if half of the body is involved, it is called as hemiplegia. So it is according to the areas of anatomical involvement, it is being classified into this type. And now coming to what are the reasons for this condition. And the main reason is decreased oxygenation to the developing brain. The brain is actively developing. If there is any hypoxic condition to the developing brain, that can lead to cerebral palsy. So it can be either due to complications labor, that is delayed labor, or the child is not coming out. The placenta has been separated and the child is not starting breathing, or there is a delay in labor is there, or there is lack of amniotic fluid, lacquer, everything is been missing. So in such complications, you can see cerebral palsy. Or it can be because of the meningitis or encephalitis immediately after birth. Or it can be because of any toxemias or any infections in pregnancy. Or it can be because of any congenital defects in the brain. Or it can be because of the connectors. Or it can be because of the poisoning of drugs or heavy metals immediately after the birth, or it can be because of any trauma. The trauma can cause any damage to the developing central nervous system, leading to cerebral palsy. And it can be the main or most commonly seen condition is premature birth, and low birth weight also is there. So increased correlation between the premature birth and the cerebral palsy is there. So if the child is premature, less than 36 weeks, 34 weeks, 28 weeks, or something like that, the chances of getting cerebral palsy is more because the brain is not completely developed, and certain areas of the brain there can be decreased oxygenations, and the development may not be completed, and that leads to cerebral palsy. So, which all according to the areas involved, you can see cerebral cortex, you can see spastic type of cerebral palsy. That is tense contracted muscles. And this is the most common type of cerebral palsy you can see. Athetotic type, that is constant uncontrolled motion of your limbs, head and eyes. So it will be like sudden, it can be sudden jerky type of movement, or it can be slow writhing type of movement. What you can see is that there'll be slight like a Parkinsonism or something like that. The child will be keep on moving his extremities, or the affected part will be keep on moving it, or it can be a sudden jerky type of movement. Rigidity on the other side, what you can see, the muscle over there will be very tight. That cannot be relaxed. So it will be in a contracted stage. If you try to move a particular area, it cannot be possible. Tremors, again, it is uncontrollable shaking, interferes with coordination. Ataxic, which affects the cerebellum, where there is poor sense of balance. That is, the child may not have a proper balance in between. Child might fall or stumbles in between. And what you can see is that this type of children, they'll be difficulty in having the depth perception. That is, to depth they cannot identify. Or if they want to climb down the stairs, or the steps, they cannot keep it properly, and they might fall. That is the ataxic type of cerebral palsy. So coming on to the types, the most common type what you can see is a spastic type of cerebral palsy. As the name indicates, there is spasm of the muscle. And this account for 70 to 80% of all the cases. And the involved muscles, what you can see is that there will be hyperirritability, and because of the hyperirritability, there will be complete contraction will be there. And once it is contracted, and later what is it will be completely tense contracted, because finally the muscles will become completely rigid, and it cannot move that particular part. And this is seen in those areas where the cerebral cortex is involved. There is limited control over the neck musculation. That is, normally we can keep our neck upright. In a newborn baby, normally when you carry a newborn baby, you need to support the neck of the newborn baby, because that neck musculature may not be completely developed, or that muscle coordination won't be there. So you need to support the neck. After some time, after 3 months or something, the child has the ability to keep the neck upright. But for these children, the spastic type of cerebral palsy, they cannot keep their neck upright. So that is a clear indicator that the child is having some neuromuscular problem. If the neck upright or child's neck is, or if the child cannot keep the neck unsupported, then that means that the child is having some problem. And difficulty in maintaining the upright posture. Suppose if the back muscles are involved, either on the one side, right side, or the left side, or the both sides, the child cannot maintain an upright posture. That means that he cannot stand erect. So what happens is that the child might be fully either bedridden, or he has to be in a wheelchair. He cannot maintain an upright posture if his back muscles are involved. The lack of coordination of intraoral, perioral, and masticatory muscles. Normally what happens is that there will be salivation, the oral cavity will be there. And these salivations, what occurs in our oral cavity, we automatically will swallow it multiple times in an hour. So that without any or involuntary, we might do that. But on these patients, because the lack of coordination, the perioral musculature and the intraoral muscles, what happens is that they won't be swallowing of the saliva. Instead, what you can see is that there will be drooling of the saliva will be there. So that is another feature what you can see. In very young babies, sometimes you might see drooling of the saliva, but after some times, they will learn that swallowing mechanism and they'll start swallowing it. So they won't be any drooling at all. There'll be impaired chewing. The chewing will be affected on these children because lack of intraoral and perioral musculature. And swallowing also will be affected. They cannot swallow. So these children, what happens is that they'll be mostly on a pure type of diet, or the diet which is completely, what is that? You might need to smash it and then they cannot chew properly. You suppose if you give some hard food, they cannot chew properly. So you might need to smash it in a mixie and then you have to give to for these children. That again might increase the caries activity. So because of the impaired chewing, persistent tongue thrust will be there because the child doesn't know the correct position of the tongue or the correct posture of the tongue. And because of that, the tongue will be always jetting out of the oral cavity, leading to spastic tongue thrust. And as I mentioned before, that is, there has been increased or lack of control of the intraoral and perioral musculature, and the tongue also will be affected. The speech also will be impaired. The child cannot speak properly. Then comes the athetotic or dyskinetic type of cerebral palsy. So athetotic type of cerebral palsy, there are two types are there, that is athetotic type and choreoathetotic type. Athetotic type is a slow, uncontrolled movements. It will be very slow type of movements is there. And choreoathetotic type will be sudden jerky movements. That suddenly there will be some movement will be there. And muscles of legs, hands, feet, and some cases face and throat might be involved and resulting in drooling of the saliva, grimacing, and speech disorders if it is affecting the perioral musculature. And these symptoms normally occurs when the child is at an emotional stress. So if the child wants to keep the mouth open, then suddenly the child closes the mouth without his intention or without his any involuntarily the child closes his mouth. So that is what you can see on these type of children. And there won't be anything while the child is sleeping. So when the child is stressed, normally what you can see, this type of movement will be there. So especially for your dental treatment, if the child comes for the dental treatment, this will be highly, you can see it because it will be highly noticeable in these children. But if the child is in the relaxed state of he is sleeping, you don't see this condition. That is athetotic type of cerebral palsy. And that accounts for a 10 to 20% of all the cases. So the most common one is the spastic type, that is 70% of the cases, you can see the spastic type. Athetotic type, you can see around 10 to 20% of cases, you can see athetotic type of cerebral palsy. There'll be, if the neck musculature is involved, there'll be uncontrolled movement of the neck. Either the neck will be moving to one side or to the other side. The child cannot keep the neck in a correct position. And if it is a slow rooting type of movement, there will be bruxism will be there. And at the same time, sudden jerky movements, that also is possible. Suppose if you are doing an injection into the oral cavity and suddenly if the pain is being inflicted to the patient, suddenly what happens is that involuntarily the child might close his mouth. So sudden jerky movement is also possible. So when you're doing some procedures on these children, you have to be extremely cautious. You might need to keep a bite block in between to injure the child and getting injured yourself also. Suppose if you're giving a local anesthesia, that pain immediately might cause Either it can lead to bruxism, slow writhing type of movement, or sudden jerky movements. Choreathytotic type of movement also is possible. And along with that, the tongue posture, drooling of the saliva, difficulty in chewing, all those things will be there on these children also. Then the third type, 5 to 10% of cases you can see this type of cerebral palsy, that is ataxic type of cerebral palsy. That is very shaky and unsteady movements. And the most common thing is a weak sense of balance and poor coordination. And depth of perception is also will be affected. As I have mentioned before, if you're climbing down the stairs, normally without light also we can climb down the stairs because we know how much depth is there. And the uniform depth also will be there. So we have that perception and we can keep on walking. But for these children, what happens is that their depth perception won't be there, so they might fall. And their equilibrium also will be not proper, and because of that also they will fall. And once they fall, what is another possible complication is that lack of coordination of the muscles also. So normally when we fall, what happens is that we will directly place a hand or legs. So what happens is that either our hand or legs might get injured or fractured if you fall suddenly. Very rarely we'll get a injury to the face, or head injury will be head injury, suppose if you fall down, because we have a cushioning effect by our extremities. But for these children, that reflexes won't be there, so they will directly fall with their face onto the floor, leading to multiple fractures of the anterior teeth. And this account for 5 to 10% of all the cases. And this has happened, or this will occur if the lesion is in the cerebellum or the hypoxic area is in the cerebellum. And the involved muscles, the child may not be completely contracted. Suppose if I want to take a particular pen or this mobile from the table, so that coordination won't be there. That is, holding on to that pen may not be possible. So that shaky movements will be there. I cannot hold on to that pen will be there. And it might take a longer time to complete the task. So I might struggle a lot to hold on to that particular object and then take it and place it on the other side, because I may not be able to complete the task that easily because of the lack of coordination of the voluntary muscles. So that is because of the ataxic type of cerebral palsy. Then another type is that rigidity, that the muscle over there will be completely rigid. And this type of cerebral palsy is seen in the case of basal ganglion. If the lesion is in the basal ganglion, we will see rigidity of type of cerebral palsy. And the voluntary movement will be slow and it will be very stiff. The child will keep on placing the legs and extremities with there will be any flexibility will not be there. So the movement also, everything will be little stiff movements and slow movements you can see on these type of children. And there can be a combination of all the above or any of the above. It can be a spastic type and ataxic type, or ataxic type and choreathytotic type, or it can be choreathytotic type and a rigidity type, or any of these combination is possible in the case of mixed type of cerebral palsy. If multiple areas are involved, or multiple areas of the brain are involved, then you can get a mixed type of cerebral palsy. So we'll see what are clinical features you can see on these type of patients. That is the neonatal reflexes. So what is this neonatal reflex? These are the reflexes which you see in the neonates. Or it will disappear after few months, or within a month or within few months, these reflexes will automatically get completely vanished, or it goes off by itself. But on these children, these reflexes will be persistent for a longer time. Even in the adulthood age also, you can see these type of reflexes. So that persistence of the neonatal reflexes are seen on these type of children. And of commonly, what you can see is that asymmetric tonic neck reflex, tonic labidinal reflex, and startle reflex. So what is asymmetric tonic reflex? When you see a newborn baby, normally they sleep in this particular position. That is, head will be turned on to one side and the arms of that side will be extended. And on the opposite side, it will be flexed. You can see on this picture. That is, head is turned onto the right side and the arms of the right side is extended. At the same time, the hand on the left side is flexed. So that is what you can see. That is a tonic neck reflex, asymmetric neck reflex. The second one is the starter reflex. What you can see, if you hear a sudden voice or sudden noise or something like that, the child will get scared. Or if you suddenly uh, keep the baby down, or holding the when you're holding the baby, suddenly make you if you place the baby suddenly onto the bed, what happens is that this particular reflex, what you can see, that is startle reflex. That is his arms. Both the arms will get extended and back of the arch will get also arch type. So that startle reflex, that what you can see on this children. Or this type of what is that? Neonatal reflexes will be there, and that will be persistent even after age also. Even in the adulthood also, you can see these type of reflexes. Suppose if you switch on the aorta, suddenly the child might get this starter reflex will be there. Then this is the labyrinthine reflex. That is now, as I mentioned before, you need to support the patient's head while you are taking a newborn baby. Until the child gets a neck control, you need to support it. Suppose if you're not taking, if you're not supporting the neck, what happens is that the neck will fall back and the body will arc and the child will move away from you. So that is the labyrinthine reflex, what you can see. All these are the reflexes, what you can see, or the neonatal reflexes that will be persistent. These reflexes are normally present in neonatal period, but after some times it goes off. But in these children, these reflexes will be persistent. Some cases you can see mental retardation because as I mentioned before, if certain part of the cerebral or central nervous system is involved, and if it is on the cognitive area, there can be mental retardation be there. And if it is affecting on the some other parts, there can be seizure disorders. That is 30 to 50% of seizure disorders will be there. Hearing impairment will be there. If the temporal lobe is involved, hearing impairment will be there. And if the occipital lobe is involved, there will be disorders in the eye will be there. The eyesight will be there. If it is involving certain areas of the brain and the speech areas is involved, that is speech will be affected. And if it can be because the other way also, because of the lack of impairment of your perioral and intraoral muscle, that also can be lead to speech impairment. Then joint contractures. What you can see, the joint will be very stiff. And another thing is that these children, if they try to walk, you can see that the toe walking. So toe walking is a normal leg because of the angle of the leg. What happens is that that joint will be stiff. There won't be any flexibility of that joint won't be there. And because of that, they will do a toe walking. So these are the things you need to see when a newborn is walking, whether he is keeping his foot flat on the floor, then it's a normal one and he is walking properly, then there is no issue. But if the child is doing a toe walking, then you can see that there is something problem with this, either with the extremities or it can be because of the central nervous system, that is because of the joint contractions. Intraorally, when you see on these children, what you can see that their periodontal diseases are high. It can be because of the poor oral hygiene and because of the soft diet they are having, because they cannot chew it properly, and because the chewing is not proper, that can lead to soft diet. Or it can be because of gingival hyperplasia, because if the child is having seizures, they might be taking phenytoin, and because the phenytoin, the side effect of phenytoin, gingival hyperplasia will be there. Because of the gingival hyperplasia, there will be food accumulation over there, leading to again the periodontal disease. So the periodontal disease in these children will be high. Dental caries also will be high because of high carbohydrate diet and lack of oral hygiene or poor dexterity. Because of the poor dexterity, they cannot clean their teeth properly. And along with that, the soft and pure type of diet also will lead to high caries in these children. Malocclusion, that also will be highly prevalent on this. That is type 2 type of malocclusion. Skeletal, that is protrusion of maxillary anterior teeth can be seen. Increased overjet, unilateral crossbite. If the one side of the maxilla and mandible is affected, what happens is that that side the child may not be chewing, that lead to unilateral crossbites can be seen. Increased overjet will be seen, and there'll be multiple fractures of the teeth also can be seen because because the increased overjet. What happens is that if the child falls down because of the ataxic type of cerebral palsy, or what is it, choreothetotic type, or the spastic type also, if the child is having any seizures or anything, suddenly the child falls down, and then because the proclined incisors, there is high chance of fracturing of the incisors. And there is lack of disharmony between the intraoral and extraoral musculature, leading to impaired chewing, then drooling of saliva, and difficulty in speaking also. Bruxism also you can see in these children, and because of the constant bruxism, there can be loss of vertical dimension. That is, the teeth will get attrited, and once the teeth will get attrited, pulp might get exposed, that lead to sensitivity for the patient. And along with that, the TMJ disorder, if it is a long-term condition, what happens is that the vertical dimension will be reduced, and that can lead to TMJ disorder. Trauma, as I mentioned before, there will be high tendency for traumatic injuries to the anterior teeth because of the increased fall in these children, and lack of what is it? Lack of control of the extremities that prevents the fall directly onto the floor, hitting onto the, that is hitting onto the face directly on the floor, leading to traumatic injuries to the anterior teeth because the extensor or the extremities may not have that good coordination to cushion the fall. So how do you manage these children? So many can be managed in our dental setting. Only thing is that we might need to take an extra time for managing this children. You might need to explain the dental procedure and make them understand what you're going to do, and then gradually proceed towards a more complicated procedure. For example, if you want to do an restoration, first you can just, with the mouth mirror, you can just see the oral cavity, see everything. Gradually, you introduce your mouth mirror into the oral cavity, examine the oral cavity. Once the child is comfortable, then you can do a polishing with your polishing brush with the micromotor. And once the child is comfortable with that also, then you can use an aerator and then do the procedure. And with under rubber dam everything. So rather than directly start restoring the tooth. So gradually, if you go for a more complicated procedure, child will be able to cope up with the situation, and then he can be managed. Even if the child wants to cooperate, sometimes that may not be possible because of the lack of coordination of muscle. So you need to understand that condition, and then you have to go accordingly. And most of these children will be in the wheelchair, and they'll be very much comfortable in the wheelchair also. So he can consider using the wheelchair or treat the child in the wheelchair itself rather than shifting the child to the dental chair, because onto the wheelchair the patient will be highly comfortable. These children will be highly comfortable because they're used to that wheelchair. So what you can do is that you can tilt the wheelchair on your lap, and you can use it as if like a dental chair, and then you can do all your procedure. And if at all the child wants to be shifted onto the dental chair, you need to ask the child whether they like to be transferred from the wheelchair to dental chair, whether they require any assistance. If they require an assistance, you can give a two assistants can carry the child from the wheelchair onto the dental chair. Or else ask the child whether he himself can be move on to the dental chair. If that is possible, it will be well and good. Because what happens is that once you take the child, or once you forcefully move the child from the wheelchair to the dental chair, what happens is that there will be these muscles will be triggered, and that will lead to spasm of those muscles. and all those involuntary movements, everything might occur. So you need to ask the patient what type of transfer the child needs, and accordingly you can do it. Then when you're making the child sit in the dental chair, you can use bean bags because our dental chair is very rigid one. There is very little cushion will be there. So these children will have an awkward positions. And when you sit on a chair which is being contoured and which is hard, they'll have difficulty in maintaining their posture. So what you can use is that you can use a bean bag insert, and onto the bean bag you can make the child sit comfortably. Or else if the child has an unnatural position of keeping the extremities, you can keep a pillow underneath and then support it also. So you need to ask what type of transfer and how you need to be supported. And as I mentioned before, these children will have a bruxism. That is, if it is athetotic type of cerebral palsy, they'll keep on closing the mouth. And if it is chorea or thetotic type of cerebral palsy, there can be sudden closure of your mouth. So to prevent the sudden closure, while you're doing your dental procedure, it will be always better to place a mouth probe inside the oral cavity so that the sudden closure can be prevented, and thereby injuring the child as well as the dentist can be prevented. Then you need to support or cradle the patient's head to control the involuntary movements. Suppose if you're doing a scaling or if you're doing a restorative procedure, there can be movement of the head will be there. So if the child moves the head in between the treatment, you cannot do a quality procedure or you cannot do the procedure properly. So in such conditions, you can ask, you can tell the child that you are going to support the head of the child and thereby injuring the child. So you can tell the parent and the child, and then you can cradle the patient's head and control the involuntary movement. And normally what we can see is that in other patients, normal patients, what we do is that we'll make the patient lie down according to our position. That is, we will make our position comfortable in an indirect vision with all our back straight, everything. We'll make them sit, and then accordingly, we'll make the patient position accordingly. But on these patients, that may not be possible because they will have an unnatural position of sitting in the chair. So you may also have to adjust with those unnatural position. So you might need to sometimes stand and then do the procedure, or you might need to do in an indirect vision. So dentists, dentists working in an uncomfortable position sometimes might be sleep. And these patients, rather than keeping it in and flat onto the dental chair, it will be better to be in a supine position so that what all saliva which is there, either it can be sucked out with your suction or else the child can swallow it. But if the patient is completely supine or flat on the dental chair, there can be difficulty in swallowing. Or if you're using an aorta, there'll be chance of lack of control of the throat muscles or the perioral musculature. Sometimes this entire water may be swallowed, or sometimes it can be aspirated. So it will be better to have a upright posture. And then to minimize the starter reflex, or abrupt movement should be avoided. And if you're doing something, you need to forewarn the patient that I am going to put on the light, or I am going to use a micromotor, I am going to use the aerota, and you show them how it works, everything, and show it on their hands, and then you directly place it into the oral cavity. Rather than directly taking the aerota and then starting preparing the cavity, because that will cause a startle reflex. And if at all possible, a rubber dam has to be used, because if we are using the rubber dam, we can get a good isolation. Along with that, the uncontrolled movement of the tongue can be prevented, because when you're preparing the cavity, the child might keep the tongue in between and it comes in between your aorta and it can lacerate your tongue, leading to bleeding and all. Such complications can be avoided, suppose if you're using a rubber dam. And thereby you can get a clear field, and thereby such complications can be avoided. So consider using a rubber dam on these children, and it has to be upright. and decrease the patient time in the dental chair, because you have to be equipped all your things what you're planning to do on that particular patient, everything you have to be well planned, and decrease the time the patient has to sit in the dental chair, so that the fatigue can be reduced, because once they get fatigued, the involuntary movements keeps on increasing and you may not be able to do the procedure. And some patients, it may not be possible to do the procedure in the dental chair. For such children, you might need to go for a pre-medication or sometimes conscious sedation, or in more severe cases, you might need to go for general anesthesia. So that is a management for your cerebral palsy. And this is a commonly asked question for your university examination. That is, your question will be, how will you manage, write about the or define handicapping condition, classify handicapping condition, write in detail about cerebral palsy. So you might need to write about the definition, the etiology for cerebral palsy, the types of cerebral palsy, the clinical features of cerebral palsy, and the intraoral features of cerebral palsy, and finally, the dental management of the cerebral palsy has to be written. So that finishes the topic on cerebral palsy.